Okay, so today, welcome. We're going to do a shoulder ultrasound. This is just a basic shoulder ultrasound that many radiology practices will replicate, but as always, you need to perform the scan as per the department protocol where it is that you're working. But at least this will give you some sort of idea as to what to expect from a routine shoulder ultrasound. As always, our first point of call is selecting the ultrasound probe of choice. So you always select the probe that's got the highest frequency that will allow you to examine or get the depth of penetration for the area that you need. This is using an L12.5, so a linear 12 to 5 megahertz probe. That's okay. Some departments you'll find that they'll have ultrasound probes sort of up and around 20 megahertz. That's probably a little bit high. Below 10 megahertz, that's probably a little bit low. So somewhere between that 10 to 18 megahertz would be the appropriate range. So when you get out there, just experiment with a few different probes and see what works best on different patients. So we've selected our ultrasound probe. Now we need to select our preset. So at the moment we're on a vascular preset, the DVT. So we're going to go to our L12.5 and shoulder preset, so musculoskeletal preset. The shoulder preset's good for structures in and around the size of the shoulder, so shoulder, knee sort of area. If we were looking at the fingers or the toes or the wrist, then we'd need to go to a preset that was dedicated to a very superficial area such as that. But a shoulder preset's a good preset and appropriate for what we're looking at today. So we're going to have a look at the shoulder, or divide it up into anterior, lateral, posterior and superior, and we're just going to work through those different areas in and around the rotator cuff as they relate to each of those different sections. So we're going to start with the long head of biceps. So biceps muscle, we've got two heads. We've got a long head and a short head. You don't routinely look at the short head. The long head though we do examine. So arm is flexed at 90 degrees, palm up, just resting on the patient's lap, and that helps to bring the long head of biceps tendon uppermost so that we can see it quite easily. I like to rest my wrist on the patient. That way I'm not carrying the weight of my arm all day. So you remember, we're always on about ergonomics and looking after yourself. So that helps to protect your shoulder. Also, the movement then is just in my fingers, and that means that you're much more stable. Instead of, we've got 3 points of articulation, your wrist, elbow and shoulder if we're carrying our whole arm. If we rest our wrist on the patient, we've just got the 1 point of articulation in our wrist. So that makes life much easier for you and improves your image quality. I scan patients like so. I find this way I can reach the machine easily. I can control the patient's arm, but how you scan is up to you. Some people will have the patient sitting on the bed. They'll sit on a chair facing the bed. Look, it's entirely up to you how you want to go about scanning. So transverse over the anterior aspect of the humerus, looking for the bicipital groove, which we can see sitting just in here. Just going to move this forwards a little. There we go. So we can see the long head of biceps sitting in here. This is the bicipital groove. This is medial and lateral. This is lesser tuberosity or tubercle, greater tuberosity or tubercle and lesser tuberosity or tubercle. Now see how the long head of biceps is really bright? That's too bright for us to scan. We'd miss things. So we need shades of grey. So that's not too bad there. As always in musculoskeletal, we need to be careful about anisotropy. So we need to be at right angles to the tendon. So you can see here, if I just slightly angle the probe, all of a sudden that long head of biceps goes from being a nice bright area to a dark area. So we don't want that. Stay at right angles. You can see the tendon sitting in there. We externally and internally rotate the arm, assessing whether or not the long head of biceps subluxes out of the bicipital groove or frankly dislocates out of the bicipital groove. This echogenic line running across the top is the transverse humeral ligament, which is really just an extension of the subscapularis tendon. And then we've got our nice big deltoid muscle with our tendinous inscriptions running through it, and we can see the subcutaneous and the skin. So we've had a look at the long head of biceps in trans. Now we're going to turn our probe through 90 degrees, looking for that nice fimbrial pattern of the long head of biceps tendon. We can see it there. Remember, anisotropy. So if I just have the probe resting on the skin, you can see the way the tendon just disappears down. It makes it very hard to see. Push a little bit in here, get that tendon fibres at right angles, and you get those nice bright white lines. And we can survey down to that musculo-tendinous junction, looking to see if there's any evidence of tears, so any hypoechoic areas, any loss of the normal fascicular pattern in the muscle here. And that all looks lovely. Back up again to the subscapularis. So here we are again, transverse over the bicipital groove, just angling the probe to get rid of that anisotropy, staying in that transverse plane, sliding medially. You can see the subscapularis sitting in there, and then we just externally rotate the hand, looking at that subscapularis as it moves. Also, by externally rotating that hand, or the arm, sorry, you can see how much more of those tendon fibres we can see than if the arm is just across the patient's chest. So use the strengths of ultrasound, that dynamic assessment ability, to have a good look. Subscapularis is a big tendon, so you need to survey all the way through, inferior all the way up to superior. So what are we looking for here? We're looking to see whether or not, as we internally and externally rotate, if there's any fluid coming out of the glenohumeral joint anteriorly. We're looking to see if there's any contour deformity. We're looking to assess the texture of the tendon, make sure we've got that nice fimbrial black and white pattern. We're looking at the underlying cortical surface to make sure it's smooth and intact. The articular cartilage, that fine black line through here, to make sure it's nice and hypoechoic. And lastly, that everything just slides and that the patient doesn't have any discomfort when we do that. Then if we just move, we're still on the anterior shoulder. In this echogenic area here, there's the coracoid. We keep the coracoid in view. Rotate our ultrasound probe anti-clockwise. And there's our acromion sitting up here. Stretching between the acromion and the coracoid, we have the coracoacromion ligament. Now, a lot of departments don't routinely look at that, but I'm showing it to you because not so much for the ligament, but for what sits underneath the ligament, because the supraspinatus tendon passes underneath that. So you can see as I move this arm, we can see structures moving underneath the coracoacromion ligament. And sometimes this is where you'll get your first inclination that there might be a tear in the supraspinatus tendon. So that's the anterior shoulder. Now we're moving over to the lateral shoulder. So keeping the hand flexed, or the arm flexed at 90 degrees, palm up, just draw the arm back. And now we're looking through the supraspinatus. I like to look in longitudinal, just increasing the gain a little. Supraspinatus is also a big tendon. It's about 2.5 centimetres in width, so you need to go all the way through it, anterior to posterior. Right? How do we know when we're anterior? Well, we can see the echogenic fibres of the long head of biceps. So if I turn through 90 degrees on that now, so you can see here the probe's at 90 degrees to the supraspinatus axis. We can see the long head of biceps, bicipital groove. Everything lateral to that is the supraspinatus. Anterior, we're back into the subscapularis, and then over the top we've got our deltoid muscle. So we'll turn back through 90 degrees into the longitudinal plane, looking at the contour of the tendon. It should have this nice Concord's nose, they used to call it. If we start from the skin down this time, we've got skin, fat, deltoid muscle here, subacromial subdeltoid bursa, supraspinatus tendon, articular cartilage, and cortical surface of the humeral head, and the greater tuberosity in here. So we just need to survey through from anterior to posterior, looking at that tendon contour, looking at that cortical surface of the bone, looking at the texture of the tendon to see if there's any evidence of a tear, such as a hypoechoic cleft, loss of volume, contour deformity, bowing of the tendon, surface due to a loss of volume because of the tear, and that nice smooth cortical surface. We always look at that in sonography. It's very important. So that's in longitudinal. Turn through 90 degrees. So we can see the long head of biceps within the bicipital groove, and then we survey down to the insertion and then back to the musculotendinous junction of that supraspinatus. So all the way through there. Once again, we've got our cortical surface, articular cartilage, supraspinatus, subacromial subdeltoid bursa, deltoid muscle, subcutaneous tissue, and then skin. So remember, it's a big tendon, so you need to look all the way through. Now, the supraspinatus is actually made up of 5 different layers, right? And everyone's a little bit different. So these areas that you see tracking through, these little hypoechoic areas, they're perfectly normal. They're part of the normal architecture of the tendon. So that's our lateral aspect of our shoulder. Now we bring the hand across the chest. You don't need to wrap it around the person's neck. Just bring it around so it stretches out those posterior structures. So if we go to our model here, so we've moved from our long head of biceps. This is the anterior shoulder. It's sitting within the bicipital groove. There's your greater tuberosity and lesser tuberosity. Subscapularis sitting in here. Coracoacromial ligament in here. We move laterally. This all should be supraspinatus here. Moving posteriorly, we're looking at the teres minor and the infraspinatus now. So we have the probe on the posterior shoulder now, positioned in an orientation like so. So along the long axis of those tendon fibres. So the infraspinatus is not injured anywhere near as frequently as the supraspinatus. However, unless you go looking for things, you'll never find them. As the old saying goes, chance favours the prepared mind. If you don't expect to see something, you never will. So please keep your eyes open. Look at the whole of your field of view. Don't just tunnel vision in on a small area. So we can see the cortical surface of the humeral head here, and here's the fibres of the infraspinatus. Once again, use ultrasound's fantastic dynamic ability to assess things as they move. Make sure things are just sliding freely and they're not catching or hurting the patient. So now I've moved a little bit more posterior, still in the same scan plane, and what I'm doing is looking at the posterior aspect of the glenohumeral joint. So we've increased our depth, our focus, and now we adjust our gain. So I've just increased our TGC, and now I'll increase the overall gain. And we're looking back here at this posterior labral structure. So the shoulder is an inherently unstable joint. The labrum is what helps to give it some stability while still retaining the ability to operate through a wide range of motion. The problem is, though, the labrum's not as strong as bone. So when we dislocate our shoulder and the humeral head here pushes out posteriorly, it can tear that posterior labrum. As a result, when we externally and internally rotate the arm, instead of in this case, where the labrum doesn't change in appearance, occasionally you'll see the labrum folding. Right? You'll see fluid coming up between the labrum and the scapula, indicating a tear within the labrum. Now, MRI is a more sensitive test than ultrasound, but if you can see it, it's worth having a look, so you might be able to raise the suspicion that there's a labral tear. We can see the nice echogenic humeral head, articular cartilage, teres minor, and then infraspinatus up here, and then deltoid muscle sitting on top. Now, if we go back to that posterior labrum, increase our depth a little bit, just medial, we've got what we call the suprascapular notch or the spinoglenoid notch. So if we take our model again, looking at the posterior aspect of the shoulder, we've got our scapula here, vertebral margin, so against the spine of scapula sitting in here, posterior glenohumeral joint here. We've just moved medially, and we're sitting in the area of this infrascapular notch or spinoglenoid notch. Now, if we just tilt the model and we look superiorly, here's our suprascapular notch. So those notches, you'll find the scapular nerve. The scapular nerve can be impinged upon by fluid from the shoulder joint if we tear that labral structure. So shoulder joint fluid can track out, it can pool in and around the nerve, compress the nerve, resulting in neurological symptoms such as muscle wasting and pain in that posterior aspect of the shoulder. And we can look for that on ultrasound. So I've just moved medially, I'm still in that transverse plane, and where we're looking is just with this dip in the contour of the scapula, and we're looking for a hypoechoic or a black area sitting in there indicating the joint fluid. Remember, they can change in size considerably. I've seen them as big as grapefruits in the back of the shoulder, and I've seen them as small as a pea. So keep your eyes open. They're a dynamic structure, they do change in size. So what I've done now is we've looked at the spinoglenoid or the infrascapular notch, sliding the probe superiorly, a little bit more gel. It starts to dry out about now. You don't need to slather it on, but you do need to have enough gel so that the probe slides freely and you can retain good contact so you have good visualization. So just sliding over that spinal scapula, you can feel the bony tissue, and then you drop into that suprascapular notch area, and once again you look for that little contour change within the margin of the scapula, and that's where we'd be looking. In this case we can see the normal striations of the muscle, so it's perfectly normal. So that's anterior, lateral, posterior. Now we're going superior, and we're looking at the acromioclavicular joint. So this is the joint between our clavicle and our acromion. So it's a very small joint. A lot of force goes through that throughout our lifetime. So around sort of from the mid-20s onwards, we start to see degenerative change in that. So I'm in the transverse plane or on the patient, so along the long axis of the acromioclavicular joint. We'll just decrease our depth, bring our focus up. You can probably narrow that focal zone down a bit as well. We're just covering the area of interest now. That'll help to keep our frame rate up. We've got some dropout here on either side, so a little bit more gel will help there. There we go. Here's our clavicle, here's our acromion. That's the capsule. That should sort of just bow out slightly from the margins of the bone like it is here. That's lovely. When it's diseased or degenerate, you'll see it bowing out like so. The bone ends are nice and smooth here. Over time we'd start to develop osteophytes, so you get little spurs, and this joint's allowed to have a little bit of movement but not too much. So if we lift the arm up and down, we can see there is some movement within that joint, but that's a normal amount of movement. So joints are allowed to wobble a little, they shouldn't wobble a lot. And then we'd move laterally on the shoulder again, so we've gone back to the supraspinatus, and we're looking for subacromial, subdeltoid, bursal impingement and or supraspinatus tendon impingement. So this is probably 80% or 90% of why we're doing shoulder ultrasounds, is to look at whether or not the supraspinatus tendon and or the overlying bursa, this echogenic line with the black line and then another it's very fine, hard to see in a normal patient, whether or not that's jamming. And they can jam in two different places. They can jam on the coracoacromion ligament, or they can jam on the acromion themselves, which is why when you assess them, you need to move all the way from the anterior to the posterior. So we're anterior now. We'll abduct the arm shortly, so lift it out to the side, and we'll be looking at this tendon contour to make sure that it doesn't change. We just want it to slide and disappear smoothly underneath the acromion and the coracoacromion ligament as we do that. So we just lift up, and this is one of the reasons I like to scan behind the patient, because I can control how they abduct the arm. I don't want them going up and down like they're trying to take off. That's no good. The probe just wobbles everywhere and you can't see anything. It's not a natural movement to do that with the arm parallel or in line with our body. Typically what we will do is bring our arm forwards and abduct. By sitting back or standing back here, you can control that and make sure that the patient doesn't bring their arm forward, which can result in a false negative. It can result in us saying the shoulder's normal when in effect it isn't. It's just our technique that's poor. The other thing is, when people have shoulder pain and you ask them to do this movement, what they'll often do is they'll hunch their shoulder to raise their arm up. Right? We don't want that. Once again, that can result in a false negative. We want the shoulder to stay nice and level and then just abduct the arm. So by placing your hand here, you can feel what they're doing, and you can explain to the patient if they're doing the wrong thing and why they're doing the wrong thing. Remember, if patients know why you're doing something, they're much more likely to cooperate and help you, which is better for them and better for us. Now, remember how I said as we lift the arm up, that tendon should just glide freely? If you watch just in this area here, at the contour of the tendon, you'll note that it starts to bow and bulge up. That shouldn't occur. Now, the bursa's normal, so this is impingement of the supraspinatus tendon. And that's the scan technique for a shoulder ultrasound. Thank you. Done, Daryl.
Beautiful.